Welcome everyone. I think it's time already to start. I wonder, is everybody listening to me?
Yes, we can hear you.
Oh, thank you. Thank you, Wesam. So welcome to our third edition for the mini online seminar series that we have the pleasure to organize between the International Society of Nephrology and GLOMCOM. This is a joint effort for teaching and education. My name is Carmen Avila-Casado. Many of you know me. I'm a professor of the University of Toronto.
It's a pleasure to join the GLOMCON community today, and it's definitely an advantage to have this activity in collaboration with our working group at the International Society. Part of my interests are also diabetic patients or patients who present with renal problems who has diabetes, because I see that in most of the cases they are not always that straightforward, and this is why I chose today's case. So our patient is a 49-year-old male. He had a history of type 2 diabetes for more than 2 years. He was also hypertensive and chronic kidney disease. His baseline creat was 1.8, and he presented with progressive generalized edema over the course of a year, accompanied by increased serum creat. He was diagnosed prior to his presentation with cancer head pancreas of 6 months. His past medical history actually was also interesting, because 3 years back, he also had a non-invasive urothelial carcinoma of the urinary bladder, which was treated by intravesical BCG twice with satisfactory follow-up cystoscopy. But then, as I mentioned, 6 months earlier to his referral, he developed obstructive jaundice, and endoscopy and biopsy revealed invasive pancreatic adenocarcinoma, grade 2. A biliary duct stent was placed, and his total bilirubin has landed from 10 to 0.3. He had also received 2 cycles of Gemzar, weekly infusions, 28-day cycle, for a total of 2 cycles. Upon presentation, his blood pressure was 160/90. He had congested pulsating neck veins. He had generalized anasarca, bilateral pleural effusion, moderate ascites, and bilateral severe lower limb edema. His investigations showed a serum creat of 1.4, urea 8C, serum albumin was 2.8, calcium 8, phosphate 6, parathermone was 356, and glycosylated hemoglobin was 9.2%. His urine analysis showed the urine protein creat ratio of 4.5. He had protein 2+, pus cells only 2 to 4, and red blood cells only 2 to 3, so not a very active urinary sediment. Hemoglobin was 8, platelets 112, and total leukocytic count was 4,000. All his immunological workup was negative. C3 and C4 were normal. They have done a SPEP, but without immunofixation, it showed no monoclonal bands. Virology, all was negative. Fundus examination showed no diabetic retinopathy. And by sonography, he had a bilateral grade 1 normal-sized kidneys. He had the moderate ascites and a pancreatic head tumor of the size of 7.5 by 4.4. And so they performed a renal biopsy. And before I proceed with the biopsy, I would like to know what would be your expectations in the biopsy. What are we expecting in this patient? So we have a patient who is a long-term diabetic, more than 10 years. He's hypertensive. He is a malignant patient. He has cancer head pancreas. He received chemotherapy, and he presented with a generalized edema, a protein creat ratio nephrotic, serum albumin 2.8, and a serum creat of 2.14. So please share with us, what would you think we are expecting to see in this patient's biopsy? Are we considering here a paraneoplastic glomerulonephritis, something which is malignancy induced? Is it only the diabetes with the diabetic kidney disease which had progressed? Is something else going on as the creat have increased from 1.8 to 2.14? Or so is it the effect of chemotherapy, or is it more than one finding?
So let me tell you that in the chat, most of the people are thinking this is membranous nephropathy. somebody's asking,